Thank you. So I'll be speaking on white cataract. White is not always beautiful. It can be treacherous as well. ये प्ले नहीं हो रहा है. So for white cataract, first thing you have to differentiate between intumescent cataract and Morgagnian cataract. In intumescent cataract, you will see the prominent sectoral markings of the anterior cortex, and it's called the mother of pearl appearance, and these are the cataract which can give rise to Argentine flag signs. Whereas in Morgagnian cataracts, the cortex is liquefied and they don't normally give rise to this problem. Now, we actually encountered two main difficulties. One is the compromised visualization of the capsule during capsulorhexis. So, staining with trypan blue is essential, and the other is unanticipated elevated endocapsular pressure, which can give rise to the Argentine flag sign. So, these are the main issues while doing rhexis. Now, in this case, if you can see, I stain the capsule, but it's inadequate. I should have restained the capsule, but I didn't, and now I have lost the capsule. So, what next? It's very difficult to visualize if you are not staining the capsule properly. So, in this situation, with much difficulty, I saw it has extended already. So, I gave a cut and decided to continue with the phaco. But in the first place, if I had stained the capsule properly, I wouldn't have ended in this problem. Phaco can still be done by lowering the parameters and doing slow motion phaco, and you can still implant the bag, but it's always better to avoid the problem. And in this case again, I didn't decompress the capsule and I ended up in Argentine flag sign. Again, whether to phaco or convert is a different proposition, but in the first place, I should have avoided the problem by decompressing the endocapsular or the endonuclear pressure. So, how to decompress the endonuclear pressure? There are several ways in decompressing the endonuclear pressure. Here I am carrying on with the phaco, and because the lens, because the hemirexes were done, as you could see, I implanted the lens in the bag. So, how to decompress the nucleus? So, I take a 26 or 24G needle with bevel down and puncture, and at the same time I aspirate the fluid from the little bit of fluid to decompress. But you can see the peripheral fluids are still there, and there can still be tendency of capsule running out, as it happens in the case. So, here it run out. If it tends to run out, you have to stop and put visco at the place where it is tending to run out, not in the center, but where it is tending to run out, and then pull the nucleus in the center, as you could see, and then once it is pulled back, you can pull it again and complete the rhexis. In this case also, after staining the capsule, I started with the rhexis. Again, I am decompressing the central portion by puncture and aspirating, but as you can see, the peripheral portion, there are still intumescence. So, it's always better to tip the rhexis in the center. I will show in a second. So, instead of doing in the center, I thought, okay, I will manage to do the rhexis, the large rhexis in the first go, because I have decompressed the central area, and it started running out. So, again, you have to recognize that it can run out and you have to stop. So, here it is running out. I put visco there, and now I will try to pull it back in the center with a jerky pull. And I tried, I failed. And I am still pulling, and it's not going out, but it's going to the periphery. So, what next? So, here what I did, I again filled it up with visco. I took a Johnson bulb, pressed where it is running out, so that actually relaxed the pressure on the zonule, and I can pull it back easily. So, this is the second trick. If it's running out and if you cannot pull it in the center, depress the sclera with a bud, and you can pull it back. So, even after central decompression, there is tendency of running out. So we have to decompress the periphery as well. That's what I'm demonstrating in this video. So I'm putting the bevel down needle, aspirating the fluid, and what I'm doing next, I'll be doing a CCC, central small CCC, so that I'm not going to the periphery, no tension that it can run out, and I'm staying in the center to do a small CCC. Once the small CCC is done, I can break the peripheral intumescence with irrigation cannula or bimanual cannula and then give a nick with a microvenous scissor. The nick should be tangential. It shouldn't be perpendicular to the rhexis, because then there will be a tendency to run out, and then you can fashion the rhexis according to your wish, because by now I have broken up the peripheral intumescence. So in case of Morganian cataract, here I am nicking with the keratome, lifting the flap up, and that releases the fluid. There is no chance of the fluid to for Argentine flag, because it's Morganian. Only problem you can have is visualization of the rhexis. Because of the fluids coming out, milky fluid, you can always wash it out, or you can inject visco where the fluid is, push the milky fluid away and carry on with the rhexis. So here I have already nicked and raised the fluid out, and I am carrying out with the rhexis. You can see if there is any Morganian fluids, you can always push it out of the way by injecting visco. Now, apart from Morganian cataract and intumescence cataract, white cataract quite often present with fibrosis. So here I am just showing the phaco, though phaco, few things you have to remember, that there is no epicortex behind in this sort of cataract. So the sharp edge can damage the PC, so you have to be careful about that. And these are normally brittle nucleus. You can chop easily, you can divide them quite easily, you can divide them into small pieces, but keep a track of the small pieces. Quite often these small pieces, they hide under the iris, and later on patient can present with iritis also, recurrent iritis. Now in this rhexis, I have faced with a problem. You can see there, I didn't notice that there is a small fibrotic area, and I'm trying to do the rhexis from there. So then when I realized that, what I did, I extended the rhexis upward and decided to go from the other side and see if I can go past the fibrotic area. Here the fibrosis has not extended to the periphery, it has extended up to this area. So my plan is to go here and complete the small rhexis and then break the peripheral intumescence. So in the first place, I didn't notice the fibrosis, but once I have noticed, I have changed my plan to plan B and completed the hemirhexis from the other side. Now sometimes you get a bigger fibrotic area. You can see there is a large area, and like a fool, I am trying to do the rhexis in the center where it's fibrosis, and it is obvious that I will fail in doing that. And I realized that late, so I decided to cut that flap which I raised with microvenous scissor, and then plan to do the rhexis around the fibrosis and to cut with venous wherever I get obstruction. So I am lifting the flap with the keratome where there was no fibrosis and trying to do the rhexis surrounding the fibrotic area. Now this area, you can see the fibrosis has extended in the periphery, so I know I have to give a cut with venous scissor there. So once I have reached there, I can see I can't go any further, so I have taken a venous scissor which is blunt enough to do two jobs. One is to cut the rhexis, and with the same thing I am holding the rhexis margin, fibrotic rhexis margin with the venous scissor, continuing with the rhexis around the fibrosis. And once I have done most of it, I change over to microrhexis forceps and complete the rhexis and carry on with the phaco. So that's 10 minutes. Thank you so much, Arup. for making me part of this IC. Oyon, sorry.
That's okay.
Both Jomoj Bhai Tora. So, thank you.
That was a wonderful presentation.